Hi, and welcome to the fourth webinar in our Conceive Baby webinar series for 2017. And tonight I'll be talking about a topic that I'm really fascinated to learn more about, and that is really the future of medicine, personalised medicine and genetics and genetic testing, and really how you can utilise that to improve your fertility health and pregnancy outcomes. So firstly, for those of you who haven't joined us previously, welcome. My name's Tasha Jennings. I'm a naturopath, natural fertility specialist, and author of The Vitamins Guide and The Fertility Diet. I'm also the director of Zycia. Zycia means life and specialises in promoting and supporting life in its earlier stages, from preconception and fertility all the way through to pregnancy and breastfeeding, including the premium nutritional supplement Zycia Natal Nutrients. And of course, founder of the Conceive Baby website, which is what you have joined us through today. And I'm thrilled to be talking tonight to Dr Natasha Andreadis, who is really an expert on this topic. It's fantastic to have her to pick her brain. Dr Andreadis is a fertility specialist and gynaecologist in Sydney, Australia. She's also trained in genetic nutrition and health coaching. Natasha is experienced in managing a wide range of fertility issues such as endometriosis, ovulation issues, miscarriage, unexplained fertility and PCOS. She is an expert in fertility treatments such as IVF, IUI and genetic testing of embryos. And she's a practitioner at Genea, who are one of the world leaders in fertility. And alongside her amazing knowledge of this IVF technology, Natasha and I really share a love of food as medicine, and she enjoys lifestyle coaching women and couples who are trying to conceive. And an extension of that, Natasha has her own YouTube channel, Dr Tash TV, which is highly worth checking out, where she highlights the importance of diet, lifestyle and nutrition and environment when trying for a baby. And Natasha is also a valued member of the Conceive Baby expert panel. So welcome, Natasha.
Thanks, Tasha. Thank you for that introduction. Thanks for asking me to talk about something that I suppose I'm quite passionate about. I don't know if I'm an expert, but I'm definitely passionate about it. And I suppose compared to a lot of my colleagues have probably quite a bit of knowledge in this area. So I feel kind of a moral obligation to share what I know and what I think is coming. So I'm going to set up my talk here. Give me one moment. Okay, so you should be able to see me there.
Yep, I think it's just coming up on the screen for everyone now. Yep, you're live now, so feel free to go.
So as I've got there, I'm talking about genomics and preconception care, but this kind of relates to everything, not just preconception care. And it'll be clear as to why I put preconception care there during my talk. I'll be talking about my own genetics as part of this talk, as well as discussing some professional cases that I've seen in my rooms and in practice. So there are a couple of my details if you wanted to email me about anything or follow any of my social media feeds. Again, I think as a clinician, it's important that I share information, and that's what I think the beauty of social media is. So that's just a few links there for you. I have no financial disclosures. So where do I start? So this is back in 2013. I had set up my rooms, my private practice, having finished doing my training, my reproductive medicine training, and having returned from overseas and doing some really grueling exams. So I was sitting there very proud because I'd finished these big, really quite stressful exams, and I thought I had all the knowledge in the world, until one day a patient walked in with her 23andMe genomic profile. So I don't know if many people know, but 23andMe were the first direct-to-consumer company launched in about 2007, where patients could bypass doctors and order their own genetic testing online. And so this patient walked in, and I'm pretty sure she had a history of recurrent pregnancy loss, and asked me, you know, doctor, can you look at my genetic panel and tell me why, or is there any reason why I'm having recurrent pregnancy loss? And all I remember was just looking at her thinking, oh, wow. And there was a massive shift, and I have to say I'm very grateful for the fact that that patient walked in that day and handed me this information, because had I not received that information on that day, I may have not gone down this path, or certainly not back in 2013. So I'm very grateful to that patient. And you know, this is what medicine's turning into. It's part of consumer-driven medicine now, and I'm also grateful for that, because I've been able to order a lot of genetic testing on myself, not having to go through a doctor. And this was a really interesting paper that was published back in 2009 in the American Journal of Ethics, which talked about the impact that genomic services was making on the medical profession. And the AMA was concerned that all these people were going out and ordering these tests, but what did it mean for doctors, and how were doctors handling it? And at that stage, maybe, well, not so much now, but people were having issues with that, and doctors just didn't know what to do. So this is just a little profile of one of the first genetic tests I did on myself. And as you can see, it looks really colorful, really messy. It's another language. And there are different genetic tests that you can do. They all look different in the way they're presented. And they're getting easier to read now. But overall, you know, there's a bunch of information there that a lot of this information we're not really aware of or understand what it means at the moment. So genomic sequencing will become a part of routine medical care. That's without a doubt. It's just a matter of time. Interestingly, there was a survey done on 3,000 US consumers, and they asked them, who do you trust with your genetic data? And interestingly, they said 90% said physicians. But of course, physicians are often way back in their learning, that a lot of them don't understand what all these genetic tests mean, but patients assume if you're a doctor, you know everything, which we know is really not the case. Raymond Kurzweil is a, wow, what is he? He's worked for Google. He's an author. He's a scientist. I think he's got an engineering background, but he's worked for many companies, including Google. And you know, we talk about Dr. Google all the time, but he made a good point about something called singularity. And he defines this as a point where progress is so rapid it outstrips human ability to comprehend it. And that's kind of a bit where the genetics information and technology lies at the moment. Eric Topol is a well-known and esteemed cardiologist and professor of genomics in the States. And I've read a few of his books, which are excellent. In one of his books, and I quote here, this is directly taken from his book, he talks about the sclerotic nature of the medical community. So sclerotic is a Greek term for hard. You know, the hard nature of the medical community. It's conservative. It can be reluctant and resistant to resistance of physicians to change, which is not a bad thing, because, you know, you don't want your doctor to just adopt anything and to try any treatment at ease. But at times it can be a bit too extensive, that kind of conservatism, and holds people back. It's almost a fear of things. And as a kind of I think a backlash to that, consumers are driving changes in medicine now. And it's because, as we know, it's the internet. It's being able to do these webinars and discuss in different forums. So there are different medical communities popping up. And of course, you know, social media is super powerful. In this book, he gives a nice diagram about old medicine versus new medicine. And if you look at that diagram on the right and the left, you've got, it's pretty much computing. So computers are changing everything, and data, information systems. You know, it's the computers that enable us to run these genetic tests. We're all wearing kind of wireless sensors, you know, that those Apple Watches, the Fitbits, etc., that can connect us with our physician, and our physicians can actually see what activities we've been up to for the last 24 hours, which beats just going into the doctors and having your blood pressure checked or your heart rate checked at spot over, you know, a 1 minute. So he's made some really good points, and you know, your husband being a cardiologist might be interested in reading Eric Topol's books.
I'll pass this on.
Yeah, but very, very esteemed cardiologist. So here's me in Genea's IVF lab. IVF, PGS, pre-implantation genetic screening, PGD, pre-implantation genetic diagnosis. So as a fertility specialist working in this area, I'm very used to, dealing with genetics. We talk about genetics all the time. We test the genetics of embryos all the time. So for me, I'm quite comfortable and very interested in talking about this area. And of course, very much curious, wanting to explore it as far as it goes. So I'll take you back to my own genetic testing now. I've done a lot of testing on myself. I've spent quite a lot of money doing this, but again, I feel it's a moral obligation, but I'm also curious about myself. That probably comes first. And in doing all these different tests, I want to know how accurate are they? What's the concordance between all these tests? And they're really not that expensive, but then again, for some people, it might be out of reach. But for me, it's a priority, so it doesn't really matter. A lot of people have done the ancestry panels. 23andMe runs an ancestry panel. This is my ancestry panel, not surprisingly, with a name like Andreadis. I have a lot of European in me, but it was interesting to see that, there was a 40% Italian, which I thought was quite interesting. So, that out of interest was something quite good to do. And I will be doing one shortly using an Australian company, Ancestry. Because I just, again, want to know how accurate these tests are. So genomics for the healthy person, can it improve your health? I believe it can. So from a personal perspective, I definitely believe it can. And having seen how it can change people in practice, I would say yes to this. So there is a role in genomics in managing healthy people and in optimizing health. So you don't want to just feel okay. You want to feel the best you possibly can every day. And genomics is being used widely in cancer and treatment. We can actually take a tumor and actually find out its genomic profile and then target that tumor with drugs. So a lot of genetic conditions, complex, rare genetic conditions have been solved with genomics. Pharmacogenomics, which I'll talk about, which is, figuring out our body's ability to break down drugs based on genes and gene expression. Prenatal testing, the environment on the genome and epigenetics, personal microbiome. So we all know about the microbiome. Genomics is important in the immune system, in developing research in that area. Infectious diseases, so a lot of stuff on Ebola and Zika has involved genomics. And aging is a big area, big business there. And I love this slide by Einstein. I'm neither clever nor especially gifted. I am only very, very curious. And I think when I see that, I think of me because I'm very curious. But I think that this should extend to anyone who is a practitioner. And so when someone comes into you, and like that patient I talked about at the beginning, be curious. Don't sit there and go, well, I don't know what that means. What's she talking about? No patient's ever going to come back asking for that, which you could easily do. But instead, be curious about it. So I think that's super important.
I love that quote. That's a great one. Yeah.
Yeah. So this is just a couple of images to remind us that the fact that we're living through an amazing revolution in healthcare. And again, it goes back to technology. We now have a digital us. Everything's digital. We're living in the information age. We've now got robots, performing operations on people. Everything's automated. We can now use automated machines to look at, assess sperm, for example. Our electronic records at hospitals will become very standard everywhere. And it's exciting and it's interesting. And here I've got a picture of a couple of gadgets I picked up when I was at a conference in San Diego on functional medicine. And I think this type of technology enables us to use different data and put that together with genomic profiling to help us, make kind of sound decisions around health. Stuart Kim is a professor at Stanford University. And I love this quote from one of the papers that he'd written. You don't wait until it's perfect before you learn it. You learn what you can. You learn the principles of how human genetics works so that you can best use new genetic discoveries as soon as they are made. So I think it's the no fear factor that I like. And it goes back to the trenches. So I see myself as a practitioner in the trenches. So I'm at the kind of the forefront. I work with a company that does a lot of research and, you know, searching and not being scared to be at the front line. And in being in the front line, you have to, I believe, you have a moral obligation to ask lots of questions, and that's where doing a lot of these tests comes into play. So let's take a bit of a course through history. So in 1953, Tony Bennett, he had a top hit, Rags to Riches. And in the same year, Watson and Crick discovered DNA, the DNA helix, and we can't forget Rosalind Franklin, the lady who pretty much gave them a massive clue, who was kind of forgotten in all of this. So we can't forget about the woman behind all of this. And then, you know, ever since then, we've come quite far, because now we realize it's not just about DNA, it's about epigenetics, and it's the gene expression that is super fundamental, and we will talk a bit about that later. But pretty much, you know, your genetics is not set in stone, and what you do on a daily basis, how you live your life, your lifestyle, what you eat, stress, etc., has an impact on gene expression. And we can't ignore the impact that the environment has on gene expression. And I think the quote by David Attenborough here is very valuable. Cherish the natural world because you're part of it and you depend on it. And often I think that a lot of people forget that we're part of the environment. DNA methylations, you may have heard of this, and gene expression. So genes can express themselves or keep themselves quiet based on what we call epigenetic markers, and one of those is DNA methylation. So a methyl group, as you can see that little diagram there, tags itself onto bits of DNA, and that usually shuts down gene expression. In some circumstances, it can cause gene expression. So that's one example of epigenetics. And as you know, folate, if you go back to that slide, folic acid is an important methyl donor. So what other factors can lead to disease? So you've got diet, we know, plays a big role in diabetes. And diabetes generally type 2 is a lifestyle condition. Certain chemicals we know cause cancer. Bacteria and viruses like HPV cause cervical cancer. And as of course, you know, smoking, doctors used to tell people in I think it was the 40s or the 50s that smoking was okay, that it was good for their health. Well, no, we know now that that's incorrect. If anything, you know, smokers probably feel better because they're inhaling, and now we probably realize we should be telling them to do yoga and breathing and focusing on that instead. So environment is a big one. So we've come a long way from a karyotype, and as people would know, this is a normal male karyotype. You're looking at all your chromosomes, 22 autosomes and a pair of sex chromosomes, and on that live about 22,000 odd genes, we think. Some of these genes are more active than others, and of course, depending on what tissue we're looking at, some genes will be expressed and others will not. 2003, we had Beyonce. She had a top hit, Crazy in Love, and in the same year, Bill Clinton basically came out and said to the world that we have mapped the entire human genome. Without a doubt, the most important, most wondrous map ever produced by humankind. And it took a lot of money to do this, and it took a lot of time. So $3 billion over 13 years, a lot of money, a lot of collaboration, but America was the main driver behind this. And today, to get your whole genome sequenced, you're looking at about $1,000, and that can be done in a few days. So we've come a long way. In 2015, Bruno Mars had the hit Uptown Funk, and in the same year, Obama was still in power. And he launched something called the Precision Medicine Initiative, which pretty much just looked at a new model of patient-powered care and research. So looking at what we call personalized medicine. And I think it's worthwhile reading this out. So most medical treatments have been designed for the average patient. And as a result of this one-size-fits-all approach, treatments can be very successful for some patients, but not for others. This is changing with the emergence of precision medicine, or an innovative approach to disease prevention and treatment that takes into account individual differences in people's genes, the environments, and lifestyles. Precision medicine gives clinicians tools to better understand the complex mechanisms underlying a patient's health, disease, or condition, and to better predict which treatments will be most effective. Now, I can't imagine anyone who wouldn't want to be managed in this way. Because I know, you go to a shop and you buy an outfit, you don't want to get the one-size-fits-all. I never like getting a one-size-fits-all outfit. I want to get a tailored outfit it's suited to me. And pretty much precision medicine is what this is all about. It's looking at people on an individual level. And, of course, we all share similar genetics in many ways, but we can't forget that we are all genetically unique. There are lots of different initiatives and research projects going on in the world, spanning from America to the UK to China and Australia. This is a flyer from a recent conference that I was interested in attending but didn't, unfortunately. But it would have been great because the Chinese are really interested in genomics, and they're, a group of people that are looking at, say, for example, genes that are responsible for intelligence. So I think that is definitely a multi-genetic condition, intelligence, and I don't know if we'll see anything that could really impact in the future in regards to intelligence, but it's definitely something to think about and interesting, I think, overall. And of course, all of this is because of technology. So DNA sequencing is something that many companies are doing. Many machines are made to drive this technology, and there's different terminologies, different types of DNA sequencing. And one that's quite hot at the moment is next generation sequencing, which we use a fair bit of in IVF, and which is used to diagnose rare conditions, infections, and to help treat and prevent common genetic diseases. So that's just a little diagram to explain what a gene's made of. It's made of exons and introns, and exons basically express themselves and introns probably don't, but may have an effect on the exon expression. So that's just a bit of terminology there. So when you do a genome sequence, you can either look at the whole genome or just look at exons and introns. And then when doing a personal genome, it's always important to look at what you're looking at. So if you look down the bottom, you've got 4 boxes. You could be targeting a person's genome and looking for a particular high-risk gene, like the BRCA gene, which is responsible for, a few genetic causes of breast cancer. And then you've got your carrier mutations, so things like cystic fibrosis, and then pharmacogenomics, which looks at genes responsible for the utilization of drugs, which I'll talk about later. And then you've got your complex common disease genotypes. For example, obesity is a very common example of that, high blood pressure. And when you're looking at genes, you want to know, okay, what does it mean? So is this gene variant? Is it pathogenic? So is it going to cause a disease? Is it non-pathogenic? So not causing a disease? Many of these gene variants, we don't know what they exactly do at the moment. And we call this the variant of unknown significance. When we look at genes, we know that they are responsible for making proteins. And proteins tell our body, cellular activity, breathing, living, everything. And it all stems from DNA. And as we know, DNA gets transcripted into RNA, and then RNA is translated into a protein. And depending, if you have an abnormal DNA or a different DNA variant, you will make a different protein. So it's all a bit of a conveyor belt. And it's important to remember the body, it's a unit. We forget that the gut is connected to the brain, that things are not separate in the body. And similarly, you can't use molecular information on its own. And so you wouldn't just be looking at someone's genome. You're wanting to look at also, ideally, proteins, amino acids, bacteria. You're going to want to look at their blood pressure. You're going to want to check their heart rate and look at some blood tests. So that's a really important thing to remember. This is an example of what a wrong protein can do. So this is an example of sickle cell anemia. So that stems from a faulty gene. And as a result of a faulty gene, a certain protein won't fold into a functional shape, and you get these red cells that are abnormally shaped, and you get a disease. So when we're looking at the effects of protein production, you've got to start at the level of DNA. So always start with 1 and then you work down. So then you look at, okay, are the effects at the DNA level? Are they at the protein level? Are they at the cellular level? So is it at not just protein expression, but what happens within each cell, the red cell, the heart cell, the muscle cell? And then you've got to look at the effects on the whole organism. So are there negative effects or positive effects? So, for example, sickle cell anemia conveys a resistance to protection against malaria. So that's what I mean by looking at things as a system. I recently took a questionnaire by the Garvan Institute here in Sydney. So they have started doing genomic sequencing, and I, out of interest, did this panel, this survey. And in that survey, they asked a few questions, and one of them was, if an incidental finding shows that I have a condition that's non-life-threatening that could be prevented or treated, then I said I think I would want to know, but it would be interesting to see what other people would tick. If an incidental finding shows that I have a life-threatening condition that could be prevented or treated, then again, I would think I'd want to know. But if an incidental finding shows that I have a condition non-life-threatening that could not be prevented and or treated, then I don't think I'd want to know, but some people may. If I received results relating to findings that identified that I was at high risk for a disorder and I were able to make changes to my lifestyle, that is diet, exercise, smoking, alcohol, to decrease my risk, I will be motivated to make changes. And I strongly agree. And that's why I did a lot of my own testing. It's important when you have a patient in front of you to ask, so what do you want from this testing? Why do you want to do it? So, doctor, I want to know if I carry the BRCA gene, because if I do, then I can actually take steps to prevent myself from developing breast cancer. And we know women have mastectomies, they have oophorectomies. Angelina Jolie is a good example of that. If I am at high risk of diabetes, then I would change my lifestyle. So that is an example that I'll come to in me. And then there's non-actionable information. So Huntington's disease, an autosomal dominant condition, with quite a distressing ending for many who have this condition. A lot of people don't want to know because they can't do anything about it. They want to know because it may affect whether or not they decide to have children themselves. So you've got to tailor the test to the patient. Actionable information. So again, this is where people can take action from genetic information. And I find that people who are having this testing are actually very motivated enough to make changes. You know, they are ready to make changes. And they are happy to spend money to do this. And they don't tend to need, you know, a lot of convincing. They're just, oh yeah, I'd like to do this, or I really want to get it going. But not all patients want their genomes tested, and a lot of them may not want it tested because they're not ready to make the change. So this is a couple of examples from my gene screen. This is my risk of developing celiac, so I have no increased risk of celiac disease. So I found this quite interesting. You know, I have a long history of sometimes symptoms related to celiac that are similar to celiac, but I realized, oh, okay, this is good to know. This looks at my yeast and alcohol metabolism, and as you can see there, I've got a pretty good alcohol metabolism. But if I was Asian, you may not have seen this similar panel. And as we know, a lot of Asians cannot tolerate alcohol because in this panel, the alcohol metabolism panel, they have a lot of gene variants, which means they cannot break down alcohol so efficiently. Here I have part of a panel looking at my eye health. My mother has a history of glaucoma, and I'm at risk of developing glaucoma genetically, also looking at this panel. So you could say, well, you know, you didn't have to do this panel to find this out. You know, you've got a family history, that's enough. But for me to see this is more than just knowing that my mum has the glaucoma condition. And so now I take more good health of my eyes and, more attention to my eyes. I pay more attention to my eyes. I make sure I see the doctor and have my pressures checked more often. This was an interesting panel to do. You know, you're looking at some of the genes, the APOE genes that are related to Alzheimer's. And, you know, if I'd done this and found that I was at risk of developing Alzheimer's, what would I do? Well, I wouldn't freak out. That's just me. I'd do as much reading as I can, and I would take as much action as I could to minimize my risk of developing the condition, because just because you have a gene change does not mean you're going to develop the condition. And that's where epigenetics comes into play. Mitochondria are the basic energy cells of each cell in our body. I'm quite interested in this area, especially when it comes to reproductive medicine, because as you know, ovarian aging very much relates to declining mitochondrial function. This I found was probably one of the most interesting parts of my panel was doing something called an AMY1 gene test, and this looks at a gene that is responsible for making amylase in the mouth that breaks down amylase, which is important in using or breaking down starches, starchy food like pasta, bread, rice, potatoes. And I have a copy number variant which is low, which is 2, which is equivalent to that of a monkey. And I found this really interesting because I've always, if I've had a lot of pasta or bread, for example, I will gain weight super easily. And this is reflected in this test. But also what's interesting is this, having such a low AMY1 means that I am at risk of developing diabetes because my body just doesn't, utilize the starches so well. So then this set me off to do a few other tests. Now, this looks at my fat metabolism, and I have to say I was really impressed by my fat metabolism because I've got apparently a very good fat metabolism. So, again, it made me understand why I do better with a high-fat diet, or when I say high-fat, good fats, of course, and I try and keep the carbs low. Not super low, but I'm very aware about my intake of pasta. I rarely have pasta, and if I do, it's going to be at lunchtime. I'll try and change things around a bit. Liver detoxification, really important. And here you've got different phases, of course. When our liver breaks things down, it does it in phases. And here you've got the CYP1A1, which I think is really interesting because it looks at estrogen metabolism. And I often wonder, a lot of women who develop endometriosis and PCOS, for example, do they have issues genetically breaking down estrogens? And should we be looking at women's profiles to further assess that? Should we be looking at all of this as part of research projects? And so there's a huge scope for this. Another gene that's really important is CYP1A2, as you can see there, important for caffeine metabolism. And as you can see here, yellow means not so good. I'm a slow metabolizer of caffeine. I thought I was a fast metabolizer, but sorry, I'm a slow metabolizer. So that competes with estrogen metabolism too. So if you're not good at metabolizing caffeine, you should be aware of it, because then that might affect how you metabolize estrogen. Any questions so far?
No, I'm fascinated. I think everyone's just sitting here like we are. I think that what you could find out is really fascinating, and I love how honest you've been in the whole screening and the understanding of the genomes and what you can find out about your own body is fascinating. So no, keep going.
Okay, this is where I was really surprised. So personal history, family history. I don't have a family history of diabetes on either side of my family. Okay, back to my grandparents, none whatsoever. I'm from a Greek background. Or going back to my ancestry panel, you can analyze that even further. But, I don't have a family history of diabetes. But when you look at my genome, I have a high risk of developing diabetes across different panels. Looking at insulin secretion as well. And that kind of freaked me out a bit. So I then did some testing, HbA1c, I did fasting glucose, and whilst they were within normal limits, they were in the higher limit of normal, closer to the, off the cutoff almost. And that made me go, oh, wow, I was quite surprised. And then I thought, well, maybe if I continued to lead the lifestyle that I was leading, that maybe I would develop diabetes, because diabetes is a lifestyle condition. And my parents live a very different lifestyle to me. And that's when I made some changes to, my exercise program. Now I do a lot more strength-based training, so I try and build more muscle, which helps me use glucose more efficiently. And I did Sarah Wilson's I Quit Sugar program, so that's another thing that I do. I'm on her forum. So I did a lot of reading around sugar, and I don't eat as much bananas as I used to, but I think it's all very relevant for what I'm trying to maybe avoid in life. And of course, this is looking at glucose meters. So, you know, as part of all this, technology has evolved, and we use apps and ads. So ads are the kind of the hardware that you add to a phone to use with an app. And here you've got an ad for that acts as a glucose meter. So patients can, you know, remotely and easily monitor their glucose levels over time, and, you know, easily give this information to their patient, to their doctors for use. Other ads that are quite clever are using smartphones to act as a stethoscope, which was developed by a company in Melbourne, actually, students in Melbourne Uni. Just as a bit of fun, I thought I'd put this slide in because this is me and my sister in that photo, and I love Brussels sprouts, and my sister hates them. And apparently there's a gene, there's a single gene change in the TASR gene that can affect whether or not you loathe Brussels sprouts. As you know, a lot of people hate coriander, and there's a gene that perhaps can explain that, a gene change. Some people like the smell of violets, others don't, and that could be related to, again, another gene. Food responses, so, you know, how sensitive am I to sodium, caffeine, and lactose? And so you can do genetic testing to look at all of this. Has knowing that I have a slow caffeine metabolism changed things for me? I'm a lot more aware of how much caffeine I am drinking, and I sometimes will go for the decaf option. But you know, in terms of sodium, I've never really liked a lot of salt on my food. And that might be a good thing, because I'm looking at my sodium sensitivity. It says increased risk of sodium sensitivity. I might be one of those people that develops high blood pressure that is amenable to salt intake. You know, so some people may stop using salt, but their blood pressure stays the same. Maybe that's because they're not sodium sensitive. And this is just an example of another gene panel, another company I used to look at my caffeine metabolism. And it was in agreement with the previous test we using another company. Again, different company, but similar results to another company. So I think this is important to look at this. So this is looking at CoQ10. Some people are not able to use CoQ10 so well, and that depends on their ability to basically make ubiquinol. So, you know how you have the difference between using CoQ10 and ubiquinol? Depending on your enzymatic activity, you may be better off having ubiquinol rather than CoQ10. So that was interesting to see. So if I ever ended up needing a statin, which I hope I never do, I might put myself on ubiquinol. Food addiction, that was a curious one. This is my mother. She has osteoporosis, and I have an increased risk of developing this based on my genetic profile. So I have to be careful, and I don't have that much calcium in my diet, and I try and have to force myself to you know, at least take a supplement on the days when I haven't had much milk or cheese or other forms of calcium. And this is an agreement amongst different panels. AMY1, interesting. So the gene I was talking about earlier about amylase production. If you have a low copy number variant in AMY1, you're less likely to, or you remove lactate from your cells when you're actually exercising. So, you know, when people cramp up after they've exercised, that's due to lactic acid. And it's interesting because I do experience that when I do training. So I try and take precautions and do stretching, etc., to minimize that. We use genomics in prenatal testing. So a lot of women are doing the free fetal DNA testing, and that's part of all of genomics. And I believe that real prevention starts before conception, which is why things like diet are so super important, and that all doctors should be addressing diet. And today I talked to the medical students at Sydney Uni, and I made a real point of that, because unfortunately at medical schools we're not really taught much about nutrition at all. And I think it's, again, their moral obligation to do more reading and more research in that area, because every single patient they come into contact with not just pregnant women or women who are trying to conceive, should be at least be asked the question, what do you have for breakfast, if you have anything? IVF, you know, it's a very diverse, dynamic field, and it's a fascinating field. And you know, genomic profiling will come into play a lot, I believe, in the future, because we'll be discussing this in the preconception forum. So it's not just going to be about designer babies and gene editing. It's going to be about optimizing health in the womb. Baby CQ project, I thought I'd put this slide up just to remind us of the fact that there is a big clinical trial going on in the States that pediatricians are running, and asking, you know, parents about what their feelings are in regards to doing genome testing in babies and in newborns. And there are concerns around this, and you know, it's important that we ask the right questions, because it's a minefield. And we've also got to think about the implications of this on a child, on a baby that has no real say in what's being done. I hope that in the future, fertility workup will include DNA testing, looking at things like mitochondria methylation, because I do believe that methylation is underlooked in reproductive medicine. There's a lot of information there we just don't see very well. And estrogen metabolism, which is a very common issue. OHSS, so ovarian hyperstimulation, is a common complication from IVF, probably less common nowadays given different protocols, but it was interesting to see that VEGF, vascular endothelial growth factor, which is thought to be the cause of OHSS, is also involved in the formation and growth of new blood vessels. And I wonder if certain women who develop this condition have a genetic change in VEGF, which predisposes them to OHSS. So, you know, in going through, mining all this data and all this information, all these questions come up. So these are some of the questions that come up for me. It was an interesting article in a magazine of fertility Sterility, well, not a magazine, a journal, a very reputable journal, that looked at polymorphisms or changes in genes on the apolipoprotein E gene and the risk of miscarriage in black and white American women. So when we're looking at miscarriage, again, it's mind-blowing, because you could look at almost any gene and wonder, you know, does this gene change mean that a patient's at risk of developing recurrent pregnancy loss? I find genomics in sports performance really interesting. And we know in the professional sports arena that a lot of exercise programs are being tailored to the athlete's metabolic and mitochondrial function. And if you look at my profile, I probably wouldn't make a very good athlete. I'd be only okay, I think. This is an interesting story. So one day I was in my rooms and I'd had quite bad period pain. And I had some tramadol in my room, and I took a couple of tramadol, and I really felt so off. I felt really ill, nausea, the pain hadn't gone away. I felt like vomiting, nearly cancelled the patients that I was about to see. And that afternoon I went to the pharmacy, the chemist that I ordered a test through called my DNA test. And this panel was looking at my ability to break down certain drugs. And the recommendation was that I should avoid things like tramadol because my body can't use it very well. And so it wasn't a surprise that I had those symptoms. So you can do this testing now, you know, Chemmart, I think it's Chemmart Pharmacy, that's where I did it. $150, that's all it cost me. It was very easy to do with a pharmacist. And pharmacogenomics has been around for about 20 years, so it's not new. And it's looking at a lot of genes that encode enzymes that help our bodies break down drugs. And again, it's powerful stuff because you're tailoring the drug to a patient's genetic makeup. This may help avoid side effects, and then maybe more benefits to the patient. They'll get more relief quicker. This is just a little slide I put up just to show how they wrote up a paper about me, because I had significant variations in 4 of the 8 genes tested. So it was probably a good thing that I did it, because if I ever needed, for example, an antidepressant, I would know which ones to start with or which doses to start with. And pharmacogenomics may certainly come through into the IVF sector as well. Which patients would benefit from certain drugs over others. And again, the panel that I did with my DNA did also kind of correlate with the 23andMe gene panel that I had done earlier. And accuracy is super important when you're looking at these tests. So as you can see here, warfarin, it's an important drug to get right. It thins the blood, and it's important to know what people are doing in regards to their sensitivity to this. So I remember as a registrar always doing blood tests to figure out what patients' blood ranges were when they were on warfarin. And you're always changing the dose depending on what that blood level was. Well, now with pharmacogenomic testing, you may be able to start the dose more accurately in patients, where you don't have to kind of do so much trial and error. Antenatal antidepressants, I think this is very important, because there are many women who are trying to have a baby who are on antidepressants, and a lot of them are chopping and changing drugs because of side effects, because it hasn't worked. And if I put myself in their position, if I was to be on an antidepressant antenatally, according to my genetic panel, I should, as you can see here, where is it? It was probably, so for example, these drugs here up here, venlafaxine, I probably wouldn't want to start with that one. I would be guided by their recommendations just down here. Paroxetine is an option. Reduce initial dose by 50%. Fluvoxamine, reduce initial dose by 25 to 50%, because I can't use those drugs very well. And I use this panel to guide management in a patient, Frieda, the pharmacist, who had severe she had severe PMS, and she trialed a number of antidepressants, and we managed to get her meds right by doing this pharmacogenomic testing before she started IVF. So the question is, what kind of metabolizer are you? Are you a poor, intermediate, extensive, or ultra rapid metabolizer? Because depending on how your body breaks down these drugs, you will have different effects, different side effects. Prince, I'm a massive Prince fan, so I couldn't help but put this one up, but you kind of wonder, what was his metabolizer status when it came to drugs like fentanyl, which kill people. So a lot of people worldwide die from opioid accidental overdose. So the benefits of pharmacogenomics is that you can hopefully reduce adverse reactions and deaths. You can improve people's quality of life, and pain is a huge issue. There's less trial and error, and the drug is tailored to that patient. And these are examples of some gene-directed drugs. I think warfarin is included in that. This is a case of an interesting patient I had who was a very stressed out, lovely accountant, Indian lady, 37, came in with infertility. And after doing some tests on her, I diagnosed her with type 2 diabetes. And she was quite surprised, and I was quite surprised actually, to see all her numbers just light up. And after discussion, we ran her genome profile, and when she saw her risk factors come up on genetic testing, she said to me, the fact that I've done the genetic testing as well really brings it home to me. So it was very powerful information for her. Ideally, I would have loved to have been able to do other omic profiles like the proteome, metabolome, and a microbiome, but that's not accessible so much in the clinical setting and the average clinical setting at the moment. Again, another patient that I fondly remember, Carmen, who's probably one of my favorite patients because she was so dynamic and interested in all of this and asked some very interesting questions. So she came in, a young lady with no period, so amenorrhea, and we figured out from the history that she was over-exercising. And as part of that, she was also concerned because she had a family history of cancer. Her dad had just passed away of cancer. Mum had cancer, was having treatment for breast cancer. She inquired about the FIT genes testing. In that testing, I saw that she would be at risk of developing issues with vitamin D and its use. And I did her vitamin D levels, and they were 18, which is super low. We then, did further testing on her bones, which took us down another path. So she was interesting because she then wanted her family to be tested. She wanted her mother to come in and have a Fit Genes test, which she did. And it was an interesting experience, her wanting to compare herself to other family members, but she also wanted to make sure that her mother was taken care of as well. This is a slide to take us to ethics and the ethical aspects of all of this. And in America, with all of this evolution of genomic information and technology, something called the Genea Act came out, Genetic Information Non-Discrimination Act, which prevents discrimination on the basis of genetic information for health insurance and employment. But what it doesn't do is protect people from things like discrimination based on life insurance and disability insurance. So that's an important thing to think about. And, could we add DNA to the list of discrimination? So we have racial discrimination, gender, ethnicity, age. Can we add DNA to this? If anyone, I don't know, have you ever seen the movie Gattaca, Tasha?
I certainly have. As soon as you put it up there, I thought we are really closer to that than scarily close, really. When we're it. Yeah.
And a lot of people ask me, aren't you scared of doing all this testing? I'm like, no, well, actually, my curiosity drive is far higher than my fear of all of this. And everyone's different, not everyone's going to feel the same way as me, and that's perfectly fine. What other concerns are there? There's concerns around privacy and identity theft. This is a recent post that I saw on Facebook, which I thought was interesting. Are employers going to be able to demand genetic test results from patients? What's that going to mean? So am I going to be less employable if I carry gene changes that predispose me to depression or anxiety or heart attack?
Opening Pandora's box a little, aren't we? Yeah.
Now there are different ways. So when you're actually giving away your genome, there are different ways that they can store that information, and they can make it very identifiable, or they can make it non-identifiable. So there are different options, and depending on what company you have your test through, you may not have an option. But what I find is most people are happy to share the genomic information to help solve and treat disease. Again, more on accuracy and technology and interpretation, a question, going back to the questionnaire at the Garvan. Given your current knowledge about genome sequencing, do you have any concerns regarding genome sequencing? And I wrote in there or ticked, I'm concerned that the sequence technology may not be 100% accurate, hence my obsession with doing lots of tests. I'm concerned about the business of medicine. So are these genetic companies making money with big drug companies? And they probably are, but if it's for the good of people, then can you argue against that? There are lots of websites where people can go on and share their information, their genetic information, to help queue it together. So 23andMe has paired with queue it together to hopefully find better treatments for people quicker. I think this is an important aspect to cover, and that's information and bioinformatic education. So all this information is coming through, but what does it mean? So for us in the future, it would mean that probably a lot of diseases will be guided or managed by treatment algorithms. So you'll be putting numbers into a computer, you'll be putting symptoms into a computer, data, and it will spit out a treatment plan for you, just like that. So that would be nice. It'd be efficient, accurate, predictive, powerful. I think as a doctor, it would be interesting. I don't want to rely completely on a computer to do that, because one of the great things about being a health professional is that you can think about things and nut things out and ask your colleagues. But if computers are more accurate and better at solving a problem, then, will we be out of a job? Who knows? And we will need more powerful computers to store and handle all this data, and you'll need experts to try and develop these complex algorithms. So future career prospects, you know, people should look into if they're thinking about what career they should go into perhaps bioinformatics and genetic counselors, and I'll talk about that in a little while. Oh, actually, I'll talk about it now because here comes my slide. But there is recently there was a conference in America, the Future of Genomic Medicine, just very recently in March, and a doctor got up and talked about the shortage of genetic counselors in the face of growing need. So basically, because of all this genomic technology and because of people's ability to order all the, there are to go around. Dr. Austin said she has a different vision. So I like to imagine a future as genome sequencing becomes more commonplace, in which we all end up in a place where we have a family genetic counselor in the same way that we have a family physician. And, you know, if genetic counseling wasn't a 2-year full-time course, I'd probably do it, to be honest. And you can have a bit of fun with genetics as well. This was a company that I'm not sure if they've gone out of business, but they shared a Facebook post, and they had quite good Facebook posts, and this was one of them where they talked about perhaps doing a spit test to analyze genetic material between couples and to find out how scientifically compatible they were. And I could imagine that a lot of these kits would be popular because people will do them out of fun, I think, in the first place. I don't think a lot of people would take them that seriously, but you never know. Aging, you know, big area when it comes to genomics, big business. I'm nearly there. Again, going back to Einstein, and I said, you know, with data comes knowledge, and knowledge is power, which is why digital information issues are a big issue. So you have to gather all this information, you have to put it together, you have to deliver it in some way that it's able to be used. Then you've got to store it, and how do you share it? Do you share it? In the Netherlands, and you know, when I looked at this, I went, oh yeah, okay. It made me think of a book written by an Australian author, Dr. Leah Kaminsky, about donating your body to science. Would you donate your body to science? So I used to want to donate my body to science, but then I always used to recall my anatomy lessons and I kind of quiver. But I would definitely and have donated my genome to science. And there are lots of different websites that encourage people to share their personal genomes. And I like what this panel says, this slide says, open humans, participate in research, share your data, learn more together. Just a few more questions, more points. Please select points below that are important to you before making the decision to have your genome sequenced. And I had ticked everything. You know, I'm concerned, will genetic counseling be available? What information can it reveal? How does the consent process work? Who will be able to access my data? How genome sequencing actually works? Understanding it, the genome sequencing, what are the implications for health insurance and life insurance? How accurate is it? And cost. Who would you trust to use your personal genetic information? I'm happy with universities, charities, research institutes. I didn't tick private companies. You know, that was last year. Would I tick it differently now? I don't know. And importantly, education. You know, we need to be educating around this. We need to start with education at school. We need to educate doctors, health providers, insurers, policy makers. And I wonder, will studies not looking at the genome become irrelevant? So if we're looking at a randomized control trial, if they have not looked at someone's genome, am I going to take it seriously anymore? So I believe that genomics in the healthy person can improve people's health. It's interesting, it's empowering, it's a useful guide to predict disease risk. You can catch disease early potentially. It's a great way to practice preventative medicine. We can avoid drugs that lead to adverse effects, and I do believe it's better than family history. What are the professional pros and cons of being involved in genomic medicine? You know, it can take a while to learn all about this. You're constantly studying, you have to spend extra time learning about it. and you have to try and incorporate it in somewhat in a business model, especially if you're in private practice. So we're looking at a new specialty in medicine that is here now. It's not just the future. So in future, which is now, we're not just going to be doing blood tests anymore. It's going to be beyond that, and beyond our senses. And I'd like to leave with a slide looking at one of my favorite entrepreneurs, which basically sums it up. We have to be curious, we have to be willing, embrace risk, and I say go for it when it comes to wanting to know more about your genomic profile. So that's my talk.
Thanks very much. I think, you know, for me personally, I found that really fascinating to discover how much we can know. And I loved your little quotes there, you know, that we are almost progressing at a rate beyond what we can comprehend, and you know, but also that we should embrace that. You know, we just learn, we go with what we know, and we maximize what we know to optimize fertility outcomes. And it's, I think you're right, it will become a mainstay in fertility treatment, because just from your discussion there, you can see how much it would obviously affect your fertility, and not only your fertility, the genes you're passing on to your baby. So if there is some way preconceptionally that we, I mean, as you've probably seen on my newsletters, I mean, my motto is being the best mum starts well before birth. And I love that this kind of proves that even more. You know, creating the right DNA, creating a healthy egg, creating the healthy sperm can have a greater impact on your child's future health than anything you do post-birth. So it's really great to see us focusing on that now. A question I personally had, I mean, you talked about all the different testing. Is there one you would recommend? And they all do the same, I guess.
I like Fit Genes. So they're a company out of Melbourne. So I like Fit Genes because they are also doing a bit of research in that area. So I'm a Fit Genes practitioner, so I've done their course and used their panels, and so I recommend them probably to start with. But, you know, there are different companies coming out and offering different things. So it's a competitive area because there's so much potential here in this field. But I think it's important to go out and explore, you know.
We'll continue to do that. So I guess thanks everyone for tuning in tonight. If you do have more questions, which I think we have opened Pandora's box a bit there, so if there are any more questions, you can jump on the Conceive Baby website, conceivebaby.com.au, and find more information and articles from myself and Natasha, and certainly drop us an email, Twitter, Facebook. We love hearing from people and your ideas and your feedback on what we're doing. We're here to help you and how to try to create the healthiest babies and lives that we can. So thanks, Natasha, for taking time out of your really busy schedule to be with us tonight. I know you are super busy. And for everyone else, I will be taking a little bit of a break over the Easter and school holidays for next 3 weeks to spend a little bit of time with my little ones, which is what we're doing this for, but also to produce the Conceive Baby podcast, which is coming soon. So do stay tuned for that. But I will be back on the 19th of April, and we'll be talking about a topic that we actually touched on a bit there, and we're talking about miscarriage prevention strategies. And I know that's a topic that is quite misunderstood in the fertility, and also a lot of questions come through the website about that. So I'll be speaking with naturopath Angela Highwood, who's internationally renowned, has clinics globally, and is very experienced in treating multiple miscarriage and recurrent miscarriage in her clinic. So if you haven't already registered for the Conceive Baby webinar series, jump on conceivebaby.com.au and follow the links. It says exclusive access to fertility specialists from the privacy of your laptop. Click on the link and you can subscribe to the webinar series there. Also, make sure you download your free copy, introductory copy of my book, The Fertility Diet, which is again on the right-hand side of the Conceive Baby website there. So until next time, wishing you all the best in health and happiness.